Good day, I am Sufumi Chibi Ayai, and for today we're gonna perform a tracheostomy tube placement in dogs. So the equipment needed includes sterile drape, back hose towel clamps, sterile gauze, suture material or surgical staples, scalpel handle number 3 and size number 10 or 15 blade, Adsanthum forceps, Mayo Hagar needle holders, 2 curved mosquito hemostat forceps, Metzibom scissors, small gulpy retractors, an umbilical tape, and a tracheostomy tube. So, an appropriate size tube needs to be 6 or 7 tracheal rings in length and have a maximum diameter of 50% of the diameter of the trachea lumen. They can be single or double lumen as well as being cuff or uncuff. So the procedure should be performed under general anesthesia. So patients in respiratory distress should be pre-oxygenated for approximately 5 to 10 minutes prior to the beginning of the procedure. As you can see, once induced, the patient should be placed in dorsal recumbency. The neck will need to be extended and a rolled up towel is placed underneath so the trachea and larynx is raised. So here I have created a model of the trachea using clay. I am aseptically preparing the animal by placing drapes and then using Bacchus towel clump followed by a 4-corner drapes and then clamps. So to mark the area, the cranial mark on the skin represents the caudal aspect of the thyroid cartilage, and on the caudal area represents the cricoid cartilage, and the midline straight mark indicates the proposed skin incision. So here I am doing a ventral midline cervical incision using a pencil grip with scalpel handle number 3 and blade number 15 just caudal to the larynx from a distance of approximately 4 to 7 centimeter depending on the size of the patient. So here we can see the subcutaneous tissue followed by a blunt dissection until we reach the midline division of the sternohyoideus muscles. As we all know, the dog's trachea consists of C-shaped cartilages that are strung together. Each of them has an alternating annular ligament. So I am now using a gulpy retractor to hold open the skin edges and clear just enough fascia. So retracting these muscles will help to protect neurovascular structures and provide better tracheal exposure. So I am making an incision in one of the annular ligaments between 4 to 6 tracheal rings. The incision of the annular ligament should not extend more than 50 to 60% of the diameter of the trachea. Long-stay sutures of silk or nylon are placed around the tracheal rings in opposite direction to open the tracheal incision. After this, we knot the sutures and tag with hemostats. So these sutures are clearly labeled and assist in the maintenance of the luminal patency, hence facilitate in the mobilization of the site for tube exchange. An appropriate tube is then gently inserted into the tracheal lumen. So cuff tubes are only used when mechanical ventilation and gaseous anesthesia are required. A 3-0 observable suture is used to close the muscles using a simple suture pattern, allowing a large opening for replacement of the tube into the trachea if necessary. So a routine surgical closure is then applied. Here I am using a surgical staples to close the skin of the patient. So the tube can be secured with an umbilical tape around the patient's neck. So post-operative techniques include a 24-hour care to prevent potentially fatal occlusion of the tube by exudates and airways and to detect tube dislodgement. So the inner cannula should be cleaned thoroughly using warm water, dried by evaporation, and then replaced. So the tracheostomy wound should be inspected daily and cleaned with sterile saline soak swabs as necessary. That's all. Thank you.